Hello friends, welcome to my channel ProsthoHub, and today we are going to discuss a new topic, that is prosthodontic rehabilitation of mandibulectomy patients. So those who are new here, my name is Dr. Jolsna, and through this channel ProsthoHub, I discuss some of the important prostho related topics that you may find useful for your university exam. And this topic, that is the prosthodontic rehabilitation of mandibulectomy patient, is a very important one which you should not miss, and it usually comes as a long essay in your exam. So let's see the contents. The contents include introduction, classification of mandibular defects, goals of mandibular reconstruction, the various diagnostic considerations, surgical reconstruction and prosthetic rehabilitation. Finally, conclusion and references. So, before getting into detail, I request everyone to please do like and share my videos and also subscribe to my channel ProsthoHub. If you have any queries or feedbacks, you can either comment below this video or you can mail me at this mail ID. So, let's get into the details. To the introduction. So we know that mandible is a single bone that creates the peripheral boundaries of the floor of the oral cavity, and the muscles of mastication are bilaterally attached to the mandible to generate a variety of complex mandibular movements useful in speech, swallowing, mastication, respiration, etc. But unfortunately, the most common intraoral site of squamous cell carcinoma, being the lateral margin of tongue and floor of the mouth, predisposes mandible for tumor invasion, and this may necessitate the resection of mandible along with large portion of tongue, floor of the mouth and the regional lymphatic system. And these resection can lead to discontinuity of the mandible, and if there is a discontinuity of mandible, it has the potential to disrupt any of these functions mentioned above. That is, there may be impaired speech articulation, difficulty in swallowing, problems with mastication, altered mandibular movements, compromised control of salivary secretions and also severe cosmetic disfigurement. So, the rehabilitation of such mandibulectomy patient should always consider to restore their form and function. Coming to the classification of mandibular defects, so there are numerous classifications like the Cantor and Curtis, the Boyd's classification or the HCL classification, Erkin et al., Laney's classification, etc. So based on exam point of view, I am only discussing the most important one, that is a Cantor and Curtis classification. If you want to know in detail about the other classifications, please do leave a comment below this video. Cantor and Curtis classification, published in 1971, divides the mandibular defects into 6 classes. The class 1, that is radical alveolectomy with preservation of mandibular continuity. So these radical surgeries remove the tumor along with the surrounding tissues and structures like lymph nodes which may contain cancer. So here in this case, along with the portion of alveolar process, we may remove the lingual and buccal sulcus mucosa, the portion of base of tongue, mylohyoid muscle, lingual and inferior alveolar nerve, sublingual and submandibular salivary glands, and also sometimes anterior part of the digastric muscle. And the features of this class, it is the least debilitating one because the mandibular continuity is preserved, but it may result in reduction in tongue mobility because of loss of some intrinsic muscles. Coming to class 2, that is lateral resection of the mandible distal to cuspid area. So here you can see the condyle, ramus and body of mandible, that is distal to the canine, is being resected along with their associated structures. The features include speech, swallowing, saliva control and manipulation of food impaired. Obviously there will be facial disfigurement, and the mandibular movements are also affected because of the loss of muscles of mastication, and there is disarticulation. The class 3 includes lateral resection of mandible up to the midline. So here the after effects will be more severe than class 1 and class 2. So the features include restricted tongue mobility due to loss of tip of the tongue and genioglossus muscle. Speech, swallowing, saliva control and manipulation of food will be severely impaired. Facial disfigurement is worsened, and disarticulation and reduction in the amount of basal bone reduces the prosthodontic prognosis. Next, the class 4, that is lateral bone graft and surgical reconstruction. So using the bone graft, we surgically reconstruct the defect area. Class 5, that is anterior bone graft and surgical reconstruction, and finally class 6, that is anterior mandibular resection without surgical reconstruction. So here the mandible is not restored surgically, so there is discontinuity. So these are the 6 classes under Cantor and Curtis classification of mandibular defects. Now let us discuss the goals of mandibular reconstruction. So the two most important goals of mandibular reconstruction, as we have discussed in our introduction, are the restoration of the form as well as function. So the mandible maintains the facial contours through support of the overlying soft tissues, and we have to restore the bony contour of the native mandible. That is, the grafted bone must be positioned as close to the original native mandible as possible, and the shape, size and position of the final grafted mandible are very important in maximizing aesthetics as well as restoring function. And it also helps in prosthetic rehabilitation of the alveolus and teeth much easier. Now next is the restoration of mastication. So the proper functioning of mandibular bone graft is essential for a good functional result. This ensures accurate indecuspation and occlusion of remaining teeth and establish the necessary relationship required for future prosthetic reconstruction. So the normal masticatory function involves synchronous interaction of the hard and soft tissues in order to manipulate, triturate and consolidate a food bolus prior to deglutition. So all these three components of mastication, that is manipulation, trituration and consolidation, are required to masticate efficiently. Similarly, deglutition is also a complex physiologic function that may be impaired by multiple mechanisms. So the surgical resection and the reconstruction technique, the radiation therapy, field and dose, and also the toxic effects of chemotherapy all impacts oral, pharyngeal and laryngeal function as well as deglutition. And also we have to ensure the correct positioning of the condyles within the glenoid fossa, thus minimizing the temporomandibular joint dysfunction. So we have to aim at restoring the proper articulation. So these are the goals of mandibular reconstruction. Next is the diagnostic considerations, which include location and extent of the mandibular defect, the presence of remaining teeth, degree of post-mandibulectomy, rotation and deviation, available mouth opening, functional limitation of the tongue, compromise of vestibular extensions, skin grafting, radiation therapy and altered anatomical relationship. So we'll be discussing one by one in detail. The foremost diagnostic determinant that must be considered is the extent of the post-surgical defect requiring rehabilitation. So we know that mandibulectomy can result in a continuous or a discontinuous defect, and the radical dissection alveolectomy can result in loss of vertical ridge height as well as vestibular depth, which may result in reduction in stability for the soft tissue supported prosthesis as well as the loss of load bearing tissue available for support. And also, the border tissues may not permit prosthesis border extension for maximum retention, support and stability. And sometimes there may be discrepancy between the level of residual osseous support and the opposing dentition at the level of occlusal plane. So this vertical discrepancy is of particular importance when the prosthesis is supported by dental implants. So in situations where continuity has been lost, the farther anterior the defect, the more disfiguring and functionally debilitating it is likely to be. So the defects of mandible that include the symphyseal region, that's the anterior defects, always require surgical reconstruction or at least segment stabilization before the prosthodontic therapy can be effective. And the main reason is the loss of key muscle attachments, that's the genioglossus, geniohyoid, which are located in the anterior mandible that control the tongue function and mobility. Whereas defects of the molar region when reconstructed surgically are likely to result in a near normal mandibular mobility and functional movement, especially when the elevator muscles of the defect site remains intact. So the anterior defects are more debilitating functionally and difficult to treat prosthodontically. To the second determinant, that is the presence of remaining teeth or implants. So usually teeth within the vicinity of planned radiation therapy with anything less than an excellent prognosis are frequently extracted prior to therapy in order to reduce the risk of future complications like osteoradionecrosis. So, the presence of remaining teeth or implants is the most important factor that determine the prognosis of rehabilitative therapy. So, more the number of teeth that is remaining, better will be the prosthodontist ability to design a restoration with maximum retention, stability and support. So, more the teeth remaining, less traumatic the function of the prosthesis is likely to be. So, we have to incorporate maximum number of teeth into the design of prosthesis if possible in order to maximize the stability of prosthesis and also to dissipate the functional forces to the greatest number of abutments. Diagnostic criteria, that is degree of post-mandibulectomy rotation and deviation. So the loss of mandibular continuity causes deviation of the remaining mandibular segments towards the defect and also rotation of the mandibular occlusal plane inferiorly, as you can see in the picture. So this mandibular deviation towards the defect side primarily occurs due to the loss of tissue involved in surgical resection. And the inferior rotation is caused by two factors, that is the suprahyoid muscles and gravity. So these suprahyoid muscles pull the residual mandibular fragment, causing inferior displacement and rotation around the fulcrum of the remaining condyle. And the second factor that causes mandibular rotation is gravity. Now, these deviation and rotation of the mandible results in facial disfigurement along with loss of occlusal contact between the remaining maxillary and mandibular teeth, and it may also lead to inability to bring the lips together for saliva control and also to initiate the swallowing process. So the treatment for this mandibular deviation and rotation is best done by restoration of continuity through osseous grafting. Other than the osseous grafting, when the restoration of mandibular continuity is not possible, we can go for early post-resection physical therapy. And other aids to minimize the deviation and rotation are mandibular resection guidance prosthesis and maxillary palatally positioned guidance ramp. Osseous grafting to be successful, there has to be certain criteria that needs to be fulfilled. First is the bone transplantation into healthy tissues. Next is wide contact should be there between adjacent bone and graft. And the recipient area should have adequate blood supply. And finally, the positive fixation. And there are several modalities for osseous grafting which include reconstruction bar with or without pedicled myocutaneous flaps, free grafts including particulate or cortical bone, and also variety of free vascularized bone flaps. Also there are mandibular reconstruction plates and screws, the most widely used aeroplastic devices for mandibular reconstruction. And the most common metals used are stainless steel, vitalium and titanium. And with the help of CAD/CAM technology, we are able to prefabricate the reconstruction plates and mini plates, and also the osteotomy cuts of bone grafts used that can be planned on three-dimensional models and duplicated at surgery with prefabricated surgical guides. Also, implant drill guides can be prepared with CAD/CAM technology. Now, when the restoration of mandibular continuity is not possible, we go for early post-resection physical therapy, that is to reposition the mandibular fragment towards a more normal position and also to minimize the effect of scar formation that will make the deviation more severe. So the physical therapy includes stretching exercises as well as reposition training. The next is the use of mandibular resection guidance prosthesis. This is an option when the residual mandible can be easily repositioned into proper alignment by manual guidance either by patient or by clinician. So if minimal pressure is required to maintain mandible in its correct position, you can go for a mandibular guide flange or maxillary guidance ramp. But a mandibular guidance prosthesis is not going to be successful and may be damaging to remaining teeth and soft tissue if maintaining the mandible in its correct position requires application of force beyond that needed to gently assist the correct repositioning. Finally, a maxillary palatally positioned guidance ramp. This is effective particularly when the deviation is less severe. So the guidance ramp may be incorporated into a palatal drop prosthesis in cases of partial glossectomy with limited residual tongue mobility. So such prosthesis serves dual purpose of mandibular guidance and also residual tongue articulation. Coming to the fourth diagnostic criteria, that is available mouth opening. So many patients experience severe limitation of mouth opening after mandibulectomy, and this may improve with time as the muscle trismus associated with surgical trauma subsides and also as the scar tissue softens. Now a simple test to determine adequate opening is to attempt to insert a stock mandibular impression tray into the mouth, and if this procedure cannot be accomplished, then rehabilitation is unlikely to occur. And stretching exercises, moist heat and analgesics will be beneficial for improved mouth opening. So these exercises may be as simple as placing a finger on the mandibular arch and pulling downward. Also various appliances are available commercially or can be custom made for the patient. And these exercises, to be of maximum benefit, it should be initiated within 2 weeks, preferably at 1 week following surgery. And sufficient mouth opening to allow dental access and making of dental impression is of paramount importance for any prosthodontic rehabilitation. The next diagnostic criteria, the functional limitation of tongue. So frequently the surgical wound is closed by suturing the remaining tissues of the floor of the mouth or the tongue to the remaining buccal tissues, and this results in limitation of the mobility of tongue depending upon the size and location of the defect. And the limitation of normal tongue mobility seriously compromise speech, swallowing, mastication and control of a food bolus and also ability to control removable prosthesis. Now the evaluation of tongue mobility can be done easily by asking the patient to extend the tongue into each cheek and also to lick the lips. If these functions can be performed, then mobility is probably adequate for the control of a prosthesis and food bolus. Now, the posterior resection of tongue is more debilitating compared to anterior tongue resection due to increased likelihood of removing motor and sensory innervation in situations involving posterior floor of the mouth or base of the tongue resections. Now, the loss of sensory innervation will severely compromise tongue function and the prognosis of prosthodontic rehabilitation. So, when the lingual nerve is sacrificed during resection, the tongue and the defect will permanently remain without any feeling, and this will affect the speech, mastication and prosthesis control on the side of the defect. So, in such situation, any prosthesis placed on the defect side only serves for cosmetic replacement of missing teeth and associated structures, and also to support the normal facial contour and to prevent the supraeruption of opposing natural teeth, as well as to assist in stabilizing and opposing complete denture. And the loss of motor innervation of the tongue is encountered less frequently than sensory innervation because the hypoglossal or the 12th cranial nerve lies deep in the floor of the mouth at the base of tongue, and it is less frequently involved in floor of the mouth or mandibulectomy resection. And we know that the hypoglossal nerve provides motor innervation to all of the intrinsic and extrinsic muscles of the tongue except for palatoglossus muscle that is innervated by the vagus or the 10th cranial nerve. And one more thing is that unlike mandibulectomy, the posterior resection is usually more debilitating than the anterior site of resection in case of tongue. So when the motor innervation of tongue is sacrificed, the prognosis for improved function with prosthodontic rehabilitation is doubtful. And loss of motor innervation of the cheek and lower lip will compromise a patient's ability to control saliva and food bolus too. Next diagnostic determinant, that is compromise of vestibular extensions. Now this is a frequently occurring problem resulting from mandibulectomy, and we know that normal vestibular anatomy is important in prosthodontics in order to allow extension of the prosthetic flanges for maximum support, stability and peripheral seal associated with retention. So when there is a loss of vestibule, it will dramatically affect the prognosis of tissue supported removable prosthesis as there is loss of normal border extension. Even when the continuity of the mandible has been restored by bone grafting, the prognosis of prosthodontic rehabilitation mainly depend upon this adequate vestibular extension. In In situations where mandibular continuity has been restored with bone grafting and implants are considered for rehabilitation, the soft tissue anatomy is again a critical prognostic indicator. So in case of normal anatomy, implants are routinely placed on the crest of the residual alveolus and it's bordered by normal vestibular anatomy, as you can see in this picture. Whereas in this case, you can see that the crest of the residual mandible or the bone graft is at the base of the V-shaped sulcus. So there is loss of the vestibular depth here, and the implants placed into this environment will present problems with soft tissue management that can result in chronic inflammation of the peri-implant soft tissues. Also, the patient may find it difficult to maintain the oral hygiene. So you can see here chronic inflammation, which can result in infection in the adjacent tissues. The provisional protective covers are fabricated to fit over the abutments, which protects the soft tissues from the sharp edges of the implant abutment, thereby avoiding soft tissue trauma and inflammation and infection to an extent. But again, it will be difficult for the patient to access for hygiene procedures, and that can complicate the soft tissue problems. So the ultimate solution to this issue is surgical recreation of vestibular depth, both buccally and lingually. Next, diagnostic determinant, that is skin grafting. So, surgical reconstruction following mandibulectomy usually involves the use of skin grafts either as a lining for the surface of resected soft tissue or as part of skin and connective tissue grafts. Even though skin is an effective load-bearing tissue, the transplanted tissue does not have sensory innervation and can be susceptible to trauma from ill-fitting or overloaded prostheses. Fortunately, skin is a relatively resistant tissue that can withstand the pressure from the prosthesis, and also the rapid turnover of keratin-producing cells in the skin graft give added protection to the underlying bone and connective tissue. But when full thickness grafting has been performed, the skin will continue to grow hair, which may be an annoying problem for the patient. So a full thickness graft includes all the layer of thick skin, whereas a split thickness graft is composed only of epidermis and a variable amount of dermis. So if skin grafting is planned without additional connective tissue grafting, every effort should be made to utilize split thickness graft so that we can avoid incorporation of hair follicles into the graft. And also the dental implants used in the sites of skin, grafted skin can create several problems, as the skin cannot tolerate the titanium surface of implant abutments and the reaction may be severe. So Michel and co-workers recommended the use of custom fabricated gold alloy components in order to solve this chronic irritation problem seen when the titanium penetrates the skin graft. Next, diagnostic determinant, radiation therapy. So, the prosthetic rehabilitation of a patient who has undergone mandibulectomy is frequently complicated by history of therapeutic radiation, that is part of the treatment given for malignancy. So, the tissues that have been radiated are fragile, sensitive to manipulation, desiccated, slow to heal, prone to infection, and there is risk of osteoradionecrosis. So, the use of adjunctive radiotherapy may compromise the success rate of prosthetic rehabilitation, and hyperbaric oxygen therapy is a method that can repair the tissue damage after radiotherapy. To the final diagnostic determinant, that is altered anatomic relationship. So the restoration of mandibular continuity is very important in determining the prognosis of post-mandibulectomy rehabilitation. So we have already discussed that farther anterior the defect, the more the disfiguring and functionally debilitating it will be. Now, when you graft the anterior mandible, it frequently results in a graft which is deficient anteriorly, and the clinical result will be one which has got the maxilla-mandibular relationship, that is severely class 2, and also there is a reduced likelihood of a completely satisfactory prosthodontic rehabilitation. This is because of the prosthodontic difficulties that the patient will be suffering from, that is the inability to provide adequate lip support for aesthetics, speech problems associated with the mandibular dentition that is placed too far lingually to allow normal articulation, inability to control a food bolus due to lack of motor function of the lip as well as muscles of lower face, excessive display of mandibular teeth due to a patient's inability to maintain the normal lip posture, difficulty in gaining adequate space for prosthesis placement without encroaching on the function of the tongue, and also the anterior bone grafting can result in misalignment of the remaining unresected mandibular fragments as well as the relationship between mandibular and maxillary teeth. So, the reconstruction, the prosthetic rehabilitation of the posterior defects with bone graft is somewhat more predictable when compared to prosthetic rehabilitation of the anterior defects. Next, we will be seeing the surgical reconstruction of mandible, and we here discuss the various materials that are used for surgical reconstruction, and this we are going to discuss in our next session. Thank you all for watching this session, and I request everyone to please do like, share and subscribe to my channel. If you have any queries or feedbacks, you can either comment below this video or you can mail me at this mail ID. So it's a bye from Prostha Hub until our second session.